let's maybe give ourselves like 5 minutes, hoping that other colleagues will join before we start. And I just hope that interpretation is already available. My name is Dr. Anderson Lat. I am the Emergency Preparedness Team Lead for the WHO Emergency Hub in Dakar, Senegal. Just to remind ourselves that we'll start in a couple of minutes. Okay, I think we have passed 5 minutes. So welcome again, dear colleagues and partners, to this session 5 of the WHO webinar series on IHR. And the topic for today's session is the WHO Pandemic Agreement. So for today, we'll have a 2 hours discussion. I will start with the welcome and housekeeping, which will be given by Amarashi. And she'll also continue with the objective of the webinar. And for the opening remark, it will be given by the Dr. Dick Shamla, who is the Program Area Manager for Emergency Preparedness at the WHO Regional Office for Africa. He's also combining the role of Hub Coordinator for the Nairobi Emergency Hub. After the opening remark, we'll have the presentation on the overview of the WHO Pandemic Agreement 2025, the key issues covered, which will be done by Dr. Mary Stephen. Dr. Mary Stephen is the WHO representative in Eritrea. So she will cover the first 12 articles of this pandemic agreement. Dr. Mary, after that, we'll have a Q&A session, which will last approximately 20 minutes. Then we'll move to the second presentation, still on the overview on the pandemic agreement, which will be covered by Dr. Hamid Magdou, who is the IHR Technical Officer at the WHO Regional Office for the Eastern Mediterranean. So we'll cover the Article 13 to 18, and it will also take care of the implementation arrangement and entry into force of this pandemic agreement. After the presentation from Dr. Magdou, we'll have the Q&A session, and then we'll conclude with the next step and closing. But in the meantime, in the interim between the presentation, we'll have, some minutes which will be allocated to some Slidos. So without taking long, let me give the floor to Amarachi to take us through the welcome and housekeeping as well as the objectives of the webinar.
Good morning, good afternoon, colleagues. Thank you for joining us. I'm just going to run us through a few housekeeping remarks. As usual, WHO events are guided by the highest ethical and professional standards, and all of us in the room, participants and panelists, are expected to behave with integrity and respect towards each other. Next slide. We have interpretation available in English and French. As you can see on my screen, you look at the bottom of your own screen and click on the interpretation button. That will be the globe icon, and then select the language that you want to listen in, and you can listen in the language that you want. We're using the Q&A session for the Q&A. We're using the Q&A function at the bottom of your screen for questions regarding the topic and the presentation. So all of the questions that are regarding the technical area that we're covering today should be put in the Q&A. And if you look at the bottom of your screen, you would see that you'd either see it as the double text chat icon or as a chat icon with a question mark as it appears on my own screen. And then we're using the chat feature for general introductions and questions regarding IT or logistics, as we're already doing right now. Please feel free to give us your name, the organization, and the country that you're joining us from in the chat. If you have problems with hearing or interpretation, please also put that in the chat, and our IT people are going to look at it and assist you. Please do not put your questions in the chat, put them in the Q&A. We can also use the chat to send you links or other information as panelists, and you are encouraged to follow those links to join the Slidos, as Dr. Ladd had mentioned today. During the live Q&A session, we would encourage colleagues to put up their hands using the raise hand feature to interact with the panelists live and ask their questions live. So if you look at the bottom of your screen too, you would see either a react button or the raised hand directly. For some people, you'll see a raised hand feature like we have in the second image there. For some other people, you would see a react image. If you click on that, one of the options that will be given to you is a raise hand feature. So you can use that to ask your questions live. Next slide. Next slide. Yeah, so by participating in this session, whether as participant or panelist, we take your attendance as permission to record your contributions, and we will be sharing this via our various learning channels. The session materials, including the recording of today and the recordings of previous sessions, will be shared with you in the days following the webinar. Next slide. All of the data that we've collected from you during your registration is kept confidential with WHO. We may be using this for communications, for surveys, for quality assurance, but be rest assured that the data will be identified before used. Next slide. The objective of today's session is to update all of us in the room on the key issues addressed by the WHO Pandemic Agreement and how they align with the amended IHR 2005 that we have been discussing in the last 4 sessions. It will also inform us about the process to be followed before the pandemic agreement enters into force. Next slide. We have the agenda that Dr. Ladd had already run us through, so I'll be skipping this. Next slide. Thank you, colleagues. Over to you, Dr. Ladd, to introduce the rest of the panelists.
You're muted. Dr. Ladd, you're muted.
Sorry. So, okay, thank you, Amarachi, for this, for the housekeeping and the objectives of the webinar. Now, let me give the floor to Dr. Dick Shamla for the opening remarks.
Okay. Habari gani? Good afternoon. Bonjour à tous. My name is Dr. Dick Chamla, and I would like to welcome all of you in the last webinar of the IHR clinics, in which WHO, AFRO, and AMRO has been organized in the past months or so. It is with a great honor actually to see all of you here in the call. We have now over 250 people who are online now, listening to us. And it is an indication of how critical issues related to international health regulations and pandemic agreement are in our global health architecture. I wouldn't really take a lot of your time on historical perspective, why the world has to have a pandemic agreement and IHR amendments. I'm sure a number of you are remembering a report in which it came from Independent Panel of Pandemic Preparedness and Response, in which it outlined issues related with the lessons learned after the COVID-19 pandemic. So, and from this report and other recommendations, we ended up with the creation of Intergovernmental Negotiation Body, INB, at the end of 2021, in which it was able to lead the negotiations of over 193 countries to come up with an instrument in which it will be able to support and actually addressing all the gaps in which were identified at the time of COVID-19 pandemic. Therefore, we have pandemic agreement in which is anchored in the principles of equity, and equity now is taken as an outcome and as a principle. And it actually trying to design and improve access to the medical countermeasures and other things, including actually capacitating our African countries or any other nations as in which are developing in order to be capable of producing its own medical countermeasures. I need to illustrate that the pandemic agreement, it was adopted this year in the World Assembly, and now we have the resolution in which it is already communicated. However, its entry into force, it depends on the prior actions in which have to be completed. As you recall, for some of you who have been part and parcel of this process, the legal architecture of pandemic agreement is a little bit complex. In a way, the updated legal architecture talking about the three instrument model, in which there have to be a parent agreement and either annex or a protocol. So although the pandemic agreement is adopted, we have to complete and agree on annexes in which are part of the prior actions in which are required. As a result, INB, the governmental negotiation body, although it completed its mandate, it created IGWIG, Intergovernmental Working Group, in which now is supporting a number of our member states in order to complete the processes of agreement on the annexes. I wouldn't want to talk more about the differences of annexes and protocol because it's all clearly articulated in the WHO Constitution, Article 30 and Article 31. But in terms of African interest, the Africa member state created an African group plus Egypt, in which there have been our ambassadors in advancing in negotiation to come up of what is happening. And now we have a non-paper on the annex in which of strategic interest of Africa, in which you will hear it more about Article 12, in which talks about PABs, the pathogen access and the benefit sharing, in which the Africa Group plus Egypt have already organized one meeting in Addis Ababa last month, in which we were able to talk about on the draft paper, in bracket, a non-paper, in which was already drafted by actually one of our member states. Therefore, it is our expectations that there have to be an agreement and consensus on the issues in which will be included in the PABS annex in order to be adopted the next year in the Waters Assembly. Africa Group plus Egypt and others in Africa were clear that they want the entry into force of pandemic agreement and annexes have to be at the same time frame. Therefore, I'm glad we are here now, and I see a lot of interest, and I'm wishing you all the best. We have brought again an excellent experts in the area from Afro region and EMNO region in order to share all their experiences and the knowledge of what is pandemic agreement. And I really do hope at the end of webinar, there will be an understanding actually of what pandemic agreement is, and on the top of the list, how the pandemic agreement and IHR instruments are interacting, who is initiated, and how is a priority and which one is not. I hope you all hear in this presentation. Without further ado, I'm wishing you all the best, and merci à tous, to you, Anderson Latt.
Thank you. Thank you so much, Dr. Dick, for this warm opening remarks, which set the scene for this session of the webinar series. So as per today's agenda, let me now give the floor to Dr. Mary Stephen. Dr. Mary Stephen is the WHO representative in Eritrea. Before joining Eritrea, Dr. Mary Stephen was the Program Area Manager for Health Emergency Preparedness at the WHO Regional Office for the Eastern Mediterranean. Before that, Mary used to work at the WHO Regional Office for Africa. Yeah, she used to take care of IHR, and she was part of this process of IHR amendment and the pandemic agreement. So, Dr. Mary Stephen, the floor is yours for your presentation. Thank you.
Thank you, Dr. Arts. Dr. Latz, thank you so much. And Dr. Dick, thank you for making my work easy with your initial opening remarks. Good morning and good afternoon to everyone. Bonjour, bon dia. Once again, welcome to this session on the pandemic treaty. So the technical presentation will be done by me and my colleague from WHO, Dr. Magub. So I'm going to take the first part, and then we will pause to take question and answers, after which we will continue with Dr. Magub's presentation. So as you heard from the presentation, I'm going to take the initial articles 1 to 12, and then Dr. Magub will complete the remaining articles. So as we heard from Dr. Dick just now in his opening remarks, and also from the IHR webinar, this is just like a refresher, just to remind us of the journey around the pandemic agreement negotiation. So this whole process started in 2020 during the assembly, when the WHO asked the WHO DG to convene independent review of the COVID-19 pandemic response. So the panels were established by the DG, and key among the panels include the independent panel on pandemic prevention and response. This was a very high-level panel co-chaired by the former president of Liberia and the Prime Minister of New Zealand. And also the IHR Review Committee on the functioning of COVID-19, on the functioning of IHR during the COVID-19 response. And then we have the existing Independent Oversight Committee for the WHO Health Emergencies Program. In addition to that, we had other committees that met and came up with recommendations. So in total, as we heard from the previous webinar, we had over 300 recommendations from all these review committees, the independent panel, around the issues regarding the COVID-19 response. And these recommendations were then grouped into 4 categories. The first group was on leadership and governance, the second group on systems and tools, the third group on financing, and the fourth one was around the equity issues. And then the Assembly established the WGPR. It was the Working Group on Strengthening WHO Preparedness and Response. So they had the mandate to look at all these recommendations and to provide advice on which of the recommendations we can actually implement using existing instruments and which ones will require new instruments. So they made finished their work and submitted their report to the Assembly. And then a special session of the Assembly in November 2021 was convened to look at the benefit of establishing a pandemic agreement. And that Assembly decided to establish the Intergovernmental Negotiating Body, which is the INB, to negotiate the pandemic agreement. And in the same process, like we said 2 weeks ago, the working group on IHR amendment was also established to look at the amendment to the IHR 2005. Okay, so like I mentioned, the IMB was mandated by the special session of the Assembly's decision to draft and negotiate a WHO convention agreement or other international instruments on pandemic prevention, preparedness, and response with a view to adoption under Article 19 of the WHO Constitution. I will explain it in subsequent slide, or under other provisions of the Constitution as the IMB deemed appropriate. So the process, how it went, it was different from the IHR amendments because this is a completely new instrument, actually completely new. And it started with those recommendations that we talked about earlier. So those 300 recommendations that were classified into 4, it was put on an online platform. And member states, including relevant stakeholders, were invited by WHO to identify which of those key recommendations they would like to see in the pandemic agreement. And this was done. I remember from AFRO, we had about 45% of AFRO countries that completed that online questionnaire. And that resulted in what was called the substantive element. So it was identified. And then this was compiled from all member states that submitted and stakeholders, which culminated into the beginning of the development of the working draft at that time. At the same time, WHO DG organized 2 public health hearings to listen to the general public, actually, to see what else they would like to add to this pandemic instrument. So that was done. And in the process also, there were different intersectional working groups that were organized to actually move the discussion forward. So this working draft for countries in AFRO, it was presented at the regional committee in 2022. And discussion continued. Member states from AFRO provided their own feedback to the documents. It was presented by the co-chair, then Precious Masoso. So it continued into conceptual 0 draft, from there to 0 draft. This is the product of lots of negotiations, actually. And then it led to the iteration of the document that was called the Bureau's text, and then the negotiating text, and then the revised negotiating text. So for AFRO, again, at the level of the negotiating text, this was presented to the regional committee in 2023 for the discussion of the ministers. Then the discussion continued. If you remember, the assembly in 2024 was, the pandemic instrument was supposed to be presented, but unfortunately, the discussion did not finish at that time because there were a lot of issues around some of the contentious articles, from Article 9 to Article 13. So many things that were not resolved. And so they were given an extension of 1 year to complete the work, which was then completed and submitted to the Assembly in 2025, this year. And this was adopted by the Assembly. As you heard from Dr. Dick's explanation, we have the PABS Annex Pathogen Access and Benefit Sharing that is still yet to be negotiated. This was a key annex for the African region. You just heard his explanation. And so the working group, intergovernmental working group, was still established from the Assembly to finish the remaining work. And the instruments, as we heard from Dr. Dick, will not come into force until the discussion on the annex is completed, which is due to be submitted to the Assembly next year. And this will be followed by the processes of the ratification and entry into force, which we are going to hear the details from Dr. Magu. Amarachi.
So colleagues, as you can
Amarachi,
see
over to you.
on the screen, you have this Slido where you are requested to provide answer to what is written. So it says, what do you understand by the word pandemic agreement? Or in French, que comprenez-vous par l'accord sur les pandémies? So please, you can scan, the QR code which is on display on the screen to answer. You scan this QR codes and you provide your answer to the question. It will last just a couple of minutes. As you can see, as you give your answer, it is displayed. Alternatively, you can use the link which is in the chat box. If you are unable to scan. Some of the colleagues are finding it difficult to answer using the QR code. You can use the link in the chat. Mary, I think you can proceed.
Okay. So we saw from the slide the different keywords in defining what the pandemic agreement is. A lot of you have taken one part or the other to describe what the pandemic agreement is. So thank you very much. I'm happy that people already have understanding about what we are discussing today. So the pandemic agreement, the general overview of it, it has 3 chapters. Chapter 1 talks about the introduction. Chapter 2 covers the article. It's titled "The World Together Equitably, Achieving Equity in and Through Pandemic Prevention, Preparedness and Response." We will go over the articles under Chapter 2. is the core business of the pandemic instruments, actually. And then chapter 3 is about the institutional arrangements and final provisions. So in total, as you can see from the screen, we have 35 articles in the pandemic instruments, which covers prevention, preparedness, surveillance, response, resilience, access to medical countermeasures, the issues of governance and financing. Some of those keywords are all in your Slido answers. So thank you very much for that. So the pandemic instrument is actually a new legally binding international instrument that supports pandemic prevention, preparedness, and response. It was adopted in May 2025, as we heard. And the objective is to prevent, prepare for, and respond to pandemic. This is in Article 2, which is guided by equity. And this pandemic agreement is expected to apply both during pandemics, but also the period in between pandemics, where there is no pandemics. We need to continue to prevent and prepare for in those periods. Then when we get into the response, we can take off from there. Okay, so just a quick highlight of what the key differences are between these two instruments. We said they are both legally binding instruments. So the pandemic agreement is negotiated under Article 19 of the WHO Constitution, as we heard from the decision of the Assembly that established the Intergovernmental Negotiating Body, while the International Health Regulations was actually negotiated under Article 21 of the WHO Constitution. There are differences between the article. You will see it in the scope. They are both legally binding instruments, as I mentioned earlier. IHR already exists. It was just amended. The pandemic agreement is a completely new instrument, and it is the second health agreement or convention or framework that was negotiated under the auspices of WHO. The first one was the Framework Convention on Tobacco Control, which is called the FCTC. When it comes to the subject of adoption, the pandemic agreement or any kind of agreement or convention is adopted normally by 2/3 majority votes. For the IHR, it's simple majority at the Assembly. So it's the member states that normally vote for this. For the pandemic agreement, it will be binding when countries ratify it. For IHR, the moment they have the simple majority, normally it will come on, it will be binding on all state parties to the IHR, unless if a country communicates areas of rejections or reservations. And for instance, the IHR 2005 amended in 2024, for countries that presented some areas of reservation and rejection, the original IHR of 2005 then applies to them, the provisions. So in terms of scope, the pandemic agreement is broader in scope. It covers any matter within the competence of WHO. They are based both on WHO Constitution, as we mentioned earlier. The IHR it has narrower scope, covering sanitary and quarantine requirements and other procedures that are designed to prevent the international spread of diseases. So this is just a quick, it's not by any means very exhaustive, but just a quick highlight of what the key areas are. And therefore, it's part of the reason why, despite the availability of the IHR, the Assembly, special session of the Assembly, still decided that there is need to establish another instrument, because some of the key challenges that were experienced during the COVID-19 pandemic, actually, to address them, the scope of IHR cannot take it. So we needed an instrument that has broader scope so that it can address those matters. And you will see the issues in subsequent slides. Okay, and the relationship between the IHR and the pandemic agreement, as we discussed in the previous session, the pandemic agreement is designed to be coherent and complementary with the IHR 2005. It is to avoid duplication, and it will not replace the IHR. I remember the session we had on the IHR amendment, we had this question asked. So it is complementary and does not replace the IHR. They both have their role to play. The issue of coordinating financial mechanism, which was established under the IHR, it will also serve the pandemic agreement to ensure efficiency, because what the issues that the IHR covers actually is like a continuum with the pandemic agreement. So they both complement each other at different levels. And then the issue of pandemic emergency, it's also defined under the IHR, and this triggers the provision of equitable access to pandemic-related products once a pandemic emergency is declared. So the IHR has it. We talked about it the last time. We said it is a continuum where you have a fake declared public health emergency of international concern, and then at the same time, the emergency committee is supposed to also look at the criteria for pandemic emergency, whether it is met. If it is met, the DG will have to consider both fake and pandemic emergency for any emergency committee that is convened for public health emergencies. Both instruments have emphasis on equitable access. As we heard from the webinar 2 weeks ago, there are also issues around health products in the IHR, which were introduced newly. It's to ensure equitable access. And they all apply the principle of equity, solidarity, sovereignty, and human rights. You'll see it in some of the definitions that we are going to go over shortly. For the IHR, we have what we call the implementation committee that oversees the implementation of the regulations, because this was one of the gaps that were identified during the COVID-19 pandemic. And then for the pandemic agreement, we have the conference of parties. Okay, so this takes me to the first set of articles, Article 1. It has mainly the definition. So I will just go over it quickly so that we can go into the key articles. So a definition of humanitarian settings was also introduced, which is a setting in which events or series of events such as armed conflict, natural disasters, or other emergencies have resulted in a critical threat to life, health, safety, security, or well-being of a community or other large group of people in need of humanitarian assistance. So this is what humanitarian emergencies are, because there are provisions both within the pandemic treaty and the IHR that also takes into account people in these settings because they have peculiar needs. Then the One Health approach is recognizing the interconnectedness between human, animal, and environmental health. And we have in this pandemic treaty an article on One Health. So the second set of definitions, we have looked at this in the webinar 2 weeks ago, the definition of public health emergency of international concern, which we said it is an extraordinary event that poses a public health risk to other countries through the spread of disease and requires a coordinated international response. So in addition to the COVID-19, we have had multiple fakes declared in the past. Public health risk is also defined as likelihood of an event that may affect adversely the health of human populations, potentially spreading internationally. And relevant stakeholders in the context of their engagement with WHO is understood in accordance with the Constitution of WHO. So this takes me to the definition of pandemic emergency, which we have also covered in the webinar 2 weeks ago. We said it is a continuum. So firstly, you will determine whether an event is a fake public health emergency of international concern, and at the same time, whether the emergency also qualifies to be a pandemic emergency. So first, it has to fulfill the criteria for the fake, and then in addition, a pandemic emergency is a fake that is caused by communicable disease that spreads widely, exceeds health system capacity, disrupts society and economy, and needs rapid coordinated action. You can read the rest of the key issues. This we have seen during the COVID-19 pandemic. It was beyond the fake. Okay, so definition of health pandemic-related products. We also define health products under the IHR. These are relevant health products, which includes vaccines, diagnostics, PPEs, therapeutics that are needed for pandemic prevention and response. And then persons in vulnerable situations is people disproportionately at risk of infection, morbidity, or mortality, as well as those that are likely to bear a disproportionate burden owing to social determinants of health in the context of public health emergency of international concern, including a pandemic emergency. So this ends the definitions. Then we go to Article 3, which talks about the issue of principles and approaches. First is sovereignty, sovereign rights. For countries, we all know it, they retain the right to make and enforce their own laws, provided they comply with international law. There has been a lot of misinformation around this area during both the IHR amendment and the pandemic treaty negotiation. It doesn't take the sovereign rights of member states. Member states still hold their sovereign rights, and they have the right to actually enact their own laws. But we are calling for alignment with the international laws and some of the provisions of the legal binding instruments that member states have signed in onto. Then the issue of human rights and dignity. Health measures must respect individual rights, including non-discrimination and gender equality. We saw a lot of things that happened during the COVID-19 pandemic when member states started closing their borders and all that. There is also a call for full respect for international humanitarian law for effective pandemic prevention, preparedness, and response. The equity is at the center of the instrument. It is represented both as a goal, a principle, and outcome of the pandemic prevention, preparedness, and response agreement. Solidarity and inclusivity, this is calling for ensuring that countries are working together alongside the stakeholders, and also recognizing that countries are not equal. The capacities vary from country to country, region to region. And then lastly, it's about science and evidence. It should be the basis for public health decision for pandemic prevention, preparedness, and response. This is coming majority from the COVID-19 pandemic. Everybody was part of it. We are all part of the response. I believe it makes sense when you listen to it because it's trying to address some of these issues. So we go into the core business, the different articles that are part of the pandemic agreement to address those gaps. So the first one is pandemic prevention and surveillance. You will see that there is also an article on surveillance in IHR, but this is supposed to be complementary. So it complements the provisions for surveillance under IHR. And parties are expected to take steps to international collaboration. to strengthen pandemic prevention and surveillance, build those capacities, and ensure that it is consistent with the provisions under the international health regulations, while taking into account national capacities and regional circumstances. So there is no one-size-fits-all kind of thing. We have to contextualize it based on the circumstances on ground. Each state party is expected to develop, strengthen, and implement national laws and programs that covers emerging and reemerging infectious diseases, collaboration across the human, animal, and environment interface, prevention of zoonotic spillovers, balancing health measures with livelihood and food security, and coordinated multi-sectoral surveillance, which is expected to facilitate detection and assessment of pathogens with pandemic potential, including zoonotic and antimicrobial resistance pathogens, and ensuring that findings are shared across relevant sectors, early detection at community level, and we strengthen mechanism for reporting of these events. And the goal is containment at source as required by the IHR. So the second paragraph under this article says that each state party shall progressively strengthen measures and capacities for pandemic prevention and coordinated multi-sectoral surveillance, taking into account national circumstances. So this, you will see the addition of things like access to safe water, sanitation, and hygiene, but also part of the prevention, strengthening routine immunization, and maintenance of strong supply chains. You will hear later about the Conference of Parties, but in the case of this article, the Conference of Parties are expected to develop guidelines and recommendations and ensure the implementation of these provisions while maintaining the consistency with provisions of IHR to the One Health approach. And there is also emphasis on ensuring that capacity building support and implementation is provided to developing countries in particular. Then this takes me to Article 5, which is talking about the One Health approach for pandemic prevention, preparedness, and response. This is a new introduction into the instruments to address, because most of the issues we are dealing with are of zoonotic origin, but to ensure that we are covering both the human health, animal health, and the environment together. So promoting One Health approach through the cycle of pandemic prevention, preparedness, and response, and of course, the relationship between humans, animals, and the environment, and ensuring coordination and integration across all the different sectors. Developing, implementing, and reviewing relevant national policies and strategies that reflect a One Health approach is needed, and establish a joint training and continuing education for workforce at human, animal, environment interface. So basically covering all the workforce from human health, from animal health, from environment, not just focusing on human health only. Then the next article, Article 6, is about preparedness, readiness, and health systems resilience. So this calls on state parties to develop, strengthen, and maintain resilient health system for pandemic prevention, preparedness, and response, while ensuring equity. Measures to be taken by state parties in accordance with their national law includes equitable access to care, so maintaining essential health services during pandemics while scaling up specific care for the pandemic. We saw it during COVID-19 pandemic. It came out very, very clearly. Supply chain management and resilience, where we have transparency and cost-effective procurement of pandemic-related products. Laboratory and diagnostics, ensuring that capacities are built at national and regional level, and we adopt biosafety and biosecurity standards, and also participate in the global networks. Then community engagement is to make sure that we are promoting and applying behavioral science, effective risk communication, and participatory approaches. So we don't wait until we have a pandemic before we start engaging the community. We engage them even before they occur. Then post-pandemic recovery. So state parties are also, as part of the preparedness, readiness, and resilience, expected to collaborate with WHO to develop and maintain national health information systems. They are also expected to monitor preparedness capacities and periodically assess these capacities, identify the gaps, and continue to strengthen them, just like we do under the international health regulations. Article 7 is about health workforce. State parties are expected to have skilled, adequate, and protected healthcare and workforce for both routine services and pandemic emergencies. Because we saw from the COVID-19 pandemic how health workers were completely overwhelmed with the cases in the hospital. So we need to have availability of adequate capacity that will help us both maintain the services, but also respond during pandemics. And state parties are called upon to strengthen national capacities, to designate or establish multidisciplinary emergency health teams. So we need to have them ready. We don't wait until we have pandemic before we start establishing. So we establish, we make sure they are trained and ready to deploy in an event of any kind of emergency. And also state parties are expected to collaborate through bilateral and multilateral mechanisms to minimize negative impact of health workforce migration on health systems. You know, we are talking about resilience, respect freedom of movement of health professionals, and also follow the WHO Global Code of Practice for international recruitment of health personnel. Countries that are affected with this, they understand what I'm talking about. State parties shall take appropriate measures to ensure decent work, protect the continued safety, mental health, well-being, and strengthen capacity of its health workforce. This will include ensuring timely access to essential health products during pandemics, eliminating inequalities, protecting health workers from harassment and violence, supporting individual and collective empowerment, development of policies for work-related incidents. This was also coming out very clearly from the response. Health workers were overwhelmed, their mental health was threatened, and somehow we forget about them. I think even at AFRO level, we saw that part a little bit later into the pandemic, that the health workers themselves are also struggling and they equally require mental health supports. On Article 8 is about regulatory system. So this is strengthening, like we said, the pandemic agreement itself is working to ensure that we have equity in access to medical countermeasures. We talked about it earlier. So under this regulatory system, state parties are expected to build and improve their regulatory bodies with support from WHO and other international organizations to also develop their legal, technical, and administrative infrastructure for expedited or emergency product approvals. Like when you have a pandemic due to a new organism, like we saw with the COVID-19 pandemic, there will be development of vaccines, therapeutics, diagnostics, and others. So they are supposed to have capacities already in place to facilitate these approvals. And of course, ongoing pharmacovigilance for safety and efficacy of all the products. And they are called upon to regularly share updates on regulatory procedures for approving pandemic-related products to also share the list and details of approved products. State parties are also encouraged to use approvals by trusted international organizations or regional regulators like WHO during emergencies. If you remember, during the COVID-19 pandemic, WHO was doing the emergency use licensing for the vaccines that were being developed, and member states were leveraging on that to also do the approval quickly at country level. So we need to have this capacity. We are also supposed to collaborate and align standards and build stronger regulatory system, especially in low resource settings like our continent of Africa. And they should also work to enhance the processes of this emergency use licensing and also pre-qualifications. Regarding research and development, so this was one of those articles that we had so much contention in addition to the subsequent articles that are coming. It's about the issue of research and development, the need to strengthen research and development capacity and also collaboration. As we all know, this capacity is not strong in Africa. And so member states are supposed to build and sustain diverse, geographically spread research and development institutions, especially in developing countries. So this is addressing our needs in Africa, promoting collaborative research, open access to knowledge, and rapid sharing of scientific results during public health emergencies of international concerns, including during pandemics. And some of the suggested areas of focus is epidemiology of emerging infectious diseases, managing pandemics, and pandemic-related health products. They also need to share information on national research priorities, agendas, and capacity building initiatives. Publishing information on well-designed clinical trials with representative population. Also ensuring access to resulting products for trial participants and at-risk communities, ensuring transparency and publication of results. So the research is supposed to be available to everyone during pandemics. Article 10 is about sustainable and geographically diverse local production. If you remember, during the COVID-19 pandemic on our continent, even PPEs at the beginning of the response was difficult for us to get. I remember at AFRO level when we were debating about the use of these cloth masks, because the surgical masks were not available even for our health workers to use in the hospitals because of our production capacity. So this is trying to address some of those issues, ensuring timely, equitable, and sustainable access to pandemic-related products by expanding and diversifying global production, especially in developing countries. Actively support WHO-led or related technology transfer and local production programs. This is also linked to Article 11. We had the mRNA transfer hub in South Africa, and in the process, a number of countries in Africa also started building capacity for manufacturing. To facilitate public-private partnerships, investment incentives, and purchasing agreements that build or expand manufacturing capacity, and also to encourage international organizations and donors to establish long-term procurement contracts with regional and local producers, especially those based in developing countries, and to align this procurement effort with equity and supply chain objectives. And upon request, the Conference of Parties can support developing country manufacturers, including through training, capacity building, and technical support for pandemic-related product development and production. This is to enhance our local capacity to be able to produce within our continent and other developing countries as well, to produce what is required to address the gaps that we had with PPEs We had gaps with vaccine. It came last to Africa. We had gaps even with the ventilators, oxygen. They were all crazily insufficient in our region. So hoping that this article will help us to build our local capacity to be able to address that gaps and prepare for future pandemics. So Article 11, the issue of technology transfer and know-how, this was also very, very contentious during the negotiation. It aims to enable sustainable, equitable, and geographically diverse production of pandemic-related health products, especially in developing countries, through proactive technology transfer, licensing, and capacity building. So what is being asked here is that if there is a technology somewhere around the world during pandemics, there should be facilitation of the transfer of those technologies, especially to developing countries, to help also with the capacity building. Then secondly is to promote and facilitate transfer of knowledge, skills, technical expertise, and know-how for local production. So not just giving us the technology, but also building the capacities of our local experts so that they can actually engage in this local manufacturing or local production. State parties are also encouraged to take steps to make public sector health licenses more available on non-inclusive and geographically broad terms, especially to benefit low and middle income countries, to encourage private right holders, e.g. the pharmaceutical agencies, to also do the same, to publish licensing terms to promote transparency and accountability. It's all geared towards ensuring that we have the capacity for local manufacturing, and so we can have access to medical countermeasures. To continue with the technology transfer, state parties are also encouraged to patent license holders to share those royalties, especially with developing countries, to improve availability and affordability during pandemics. There were some waivers that happened during the COVID-19 pandemic, but there is also room to do more. To provide resources and training to local and regional manufacturers in developing countries to build technical and production capabilities needed to apply technology transfer. To work with international and regional organizations on time-bound basis to scale up production of pandemic products. And the aim is to increase availability, accessibility, and affordability, especially during fakes and also pandemic emergencies. We have explained this earlier on. We want to make sure that it is equitably accessible to developing countries, available and affordable. I remember during the COVID-19 pandemic, those early stages of the vaccine production, even when you have the money in a country in Africa, you are not able to purchase because of the competition in the markets, and other countries that are more buoyant than countries in Africa, they bought more than what they even need for their population. So it's to break down that and ensure that there is access for everyone. In collaboration with WHO, countries must identify and create mechanisms that promote technology transfer, intellectual property pooling, especially to support developing countries, encourage transparent, non-exclusive licensing models, increase participation of manufacturers in global south, meaning countries in developing nations, in the development and production of pandemic products. So hopefully this is going to address some of those challenges that we faced. Establishing a system for safe, transparent, fair, and equitable access to and benefit sharing from pathogens with pandemic potential and their genetic sequencing. So this Article 12 actually was one of the 4 articles that the African region was promoting. Article 12, pathogen access and benefit sharing. So the PAPS instrument, as you heard from Dr. Dick earlier in his opening remarks, is going to be an annex to the pandemic agreement. And this is the reason for establishment of this intergovernmental working group to negotiate it, and it's going to be presented to the Assembly in 2026. So it will define the key terms, pathogens with pandemic potential, the modalities for access and benefits, legal basis, and WHO's coordination role. If you remember, the issue of PAPS is also being addressed under the pandemic influenza framework, where pathogens are shared by developing nations. And when developing nations share those pathogens, they are expected to benefit from whatever thing that comes out of these pathogens, whether it is vaccine that has been developed, a diagnostic or whatever, they need to share in the benefit. So in a pandemic, so you remember we defined pandemic emergency earlier, and we said it is under the IHR, which is supposed to be a continuum from fake. So when there is a declared pandemic emergency, manufacturers that use these PAB materials, they should provide 20% of their real-time production of vaccine, therapeutics, and diagnosis to WHO. 10% of this is going to be a donation. The remaining 10% will be sold at affordable prices. This applies under legally binding contracts with WHO. This is to ensure that there is access to these diagnostic, therapeutics, and vaccines during pandemics. WHO will distribute these tools based on public health risks and needs, prioritizing developing countries. If you remember, this is working somewhat like the COVAX, where there was pooling of the vaccine, and countries that could not afford it, at least were able to get some of those benefits from the COVAX. The global supply chain and logistics network may support the distribution of these medical countermeasures, and the implementation must be fair, transparent, accountable, and equitable. So it will not be a situation again that is based on my ability to pay for it, right? But it should be available, that quantity, 20% during pandemics, and it will support all countries with emphasis on developed countries. And this will be supported by WHO and international partners. Over to you, Amarachi, with the slide.
So colleagues, you have the Slido, and for this one, you are requested to provide in a few words what is the key difference between IHR and the pandemic agreement. And those who are French speaking, you can see, on demande, selon vos propres termes, quelle est la principale différence entre le RSI et l'accord sur les pandémies. So please scan the QR code using your telephone, or you go to the chat box. There is a link which you can access and provide your answer. We just have 2 minutes for this slide. So also, if you have any question, feel free to put your question in the Q&A feature. And also after this presentation, we'll have a Q&A session.
Okay, Dr. Lat, I think we have had enough of the responses. I'm glad that people have gotten so much. I can see all the answers. I'm happy to see the answers. So it means that they are really listening into the presentations. So thank you very much for paying attention. This brings me to the end of my presentation. I'm waiting to answer your questions.
Thank you so much, Dr. Mary Stephen, for this brilliant presentation, which provides an overview on the pandemic agreement covering the first 12 articles. So colleagues, now it's time for questions and answer. If you have any question, please raise your hands. The panelists will be happy to respond. But in the meantime, let me maybe read some of the questions in the Q&A. We have a question from Bello Mohammed on the malaria vaccination. He says, please, concerning malaria vaccine, what is the current situation? He said he's talking about the availability and instructions for use. Who is happy to take this one?
Yeah, Dr. Lat.
Yes, Michael?
Yeah, let me respond and colleagues can join in. So in terms of supply, actually there's no issue to do with that. Currently with the two vaccine products available, the R21 and then the RTSS. The 21 countries have introduced with either product, mostly subnationally. We have these two products in use. And the major constraint now is the funding. That's the further interventions as well. Gavi is only able to support introduction to up to 85% of the total target population in moderate to high transmission areas. So it's up to countries to see how the deficit can also be funded. So that is my immediate response to you. Thank you, Emma.
Thank you so much, Michael, for this brilliant contribution. Just to remind everyone, apart from the main presenters, we also have other members of the panel. We have Alan, we have Miriam, we have Tieble, we have Dr. Bukare, Michael, of course, and Mary and Makub. So there are other questions. Thank you to panelists who have responded to some of the questions in the Q&A. We still have some questions. There is one from Venus. We're saying, how is WHO working with African Union, Africa CDC in ensuring adoption and implementation of the pandemic agreement? Are there measures, to avoid duplication of efforts when engaging member states? Is there a framework for collaboration between WHO and Africa CDC?
Dr. Nat, also just to let you know that we have a hand up.
Okay. So I do not see this hand, so the person can go ahead and ask his question.
Good morning, Dr. Lad. Good morning to all the panelists, and thank you, Dr. Mary, for the enlightening presentation. It's Dr. Dandaswell from Cameroon. What I could get from the presentation is that besides the broader scope that the pandemic treaty has, and emphasis being made on sharing resources, research and development, procurement, and generally countermeasures, access to countermeasures. I wanted to know if practically on the field for state practice implementation, are there major differences between the IHR and the pandemic treaty, and will provisions be made like tools? We have the IHR monitoring and evaluation framework, as well as the National Action Plan for Health Security, which somehow guide countries for the implementation of IHR. Would such tools and provisions be made for the pandemic treaty as well? And concerning the PAPs, I wanted to know if it goes in line with the capacity for biobank development recommended by IHR, and if countries will benefit some form of help through these PAPs to develop these biobanks, which are essential for development of these pathogen countermeasures. Thank you.
Thank you, Joel, for your question. Can any of the panelists take this one?
Yes, so regarding the support for adoption of the pandemic instruments and how WHO and Africa CDC is working, yes, WHO and Africa CDC have a framework for collaboration. And also during the pandemic agreement negotiations, we both worked together to support member states from the continent on their effective engagement during this. Please don't go. We have another session after this. We are just breaking to ask questions. I see people leaving. We have another session to continue with the remaining articles. Please remain on the meeting. So we are supporting together. We have a framework of collaboration. The adoption, it's co-ratification, it's member states' specific responsibility, but of course, WHO and every other international organization, including Africa CDC, will support member states after they have adopted, or even in the process with the legalities of the process, as we heard from the presentation last week on the IHR domestication. The same thing will apply with the pandemic treaty. The PAPs, the details of the PAPs is not complete. Dr. Joel is going to be negotiated, and we will see the details when it is presented to the Assembly in 2026. But in general, regarding tools and everything that is needed to support the implementation of the pandemic instrument in countries, WHO will work with other partners to support, just like with the IHR. Thank you, and over. If anybody wants to add anything, please feel free to jump in. The panelists.
Yeah, maybe just to add that while we had the adoption at the World Health Assembly, the member states agreed to the pandemic agreement, once the annexes are completed, the ratification will be a formal process where countries sign, even other parties that are in agreement can also sign, but it will be a formal process. And once the country signs and agrees to it, it then becomes bound by it within a month. Our next presenter is going to go through the process of the ratification. If we can hang on, we'll get more information. If we can hang on, we will get more information about it. Maybe I use this opportunity also to further emphasize that, as our speaker has highlighted, I see the questions are still coming up about the difference between the IHR and the pandemic agreement. To start with, we say that they are complementing each other. But the pandemic agreement goes beyond to address issues that were not highly emphasized in the IHR, including the equity, especially in response and sharing of the materials that are needed. It highlights on something that is very sensitive but maybe important, the pathogen access and benefit sharing. This is not touched at all in the IHR. And then the technology transfer from north to south so that we have enough production. Immediately we have confirmation of a pandemic or a fake. It also talks about the issue of solidarity more. There are similarities like the inter-country collaboration, the importance of limiting the spread, the capacity building for preparedness, prevention, and response. Those are similarities, but there are a few issues maybe you have heard by now, following your question, that the pandemic agreement tries to address in detail. And one of the reasons why it is not yet into force is because there's still more negotiations on this pathogen access. Once you access the pathogen and you produce the product, how do you share it then? The benefits. That has been quite a key issue exposed by the previous pandemic, and several of these other gaps were exposed by the pandemic. And the agreement tries to address this. I hope that it is getting clearer as we go, because I see that question keeps coming up that people are not understanding the difference. Yeah, thank you.
Okay, thank you, Miriam, for the clarifications. Yes, there are still some questions in the Q&A. So colleagues, panelists will answer to these questions as they are coming. In the interest of time, colleagues, now let's now have the second presentation, which will be, a follow-up to the presentation from Mary. This presentation will be done by Dr. Hamid Magoud, with our colleague from AFRO. He is the technical officer in charge of international health regulations at the WHO Regional Office for the Eastern Mediterranean. Hamid, over to you.
Okay, thank you so much, and thank you so much for Dr. Mary for the comprehensive presentation. So good afternoon, everybody. The previous slide, please. Yes. So just for interest of time, directly to the topic, as a continuation of Dr. Mary presentation, Article 13, the supply chain and logistics. So there is a network called the GSCL, the Global Supply Chain and Logistic Network. This network is established to enhance the accountability, the effectiveness, and the efficacy in the global supply and distribution in response to emergencies, public health emergencies of international concerns, and pandemic emergencies. Generally speaking, the purpose of the global supply chain and logistic is to address the barrier to access during public health emergencies of international concern, as I just said, including pandemic emergencies. So the disruption in the supply chain that has been noticed during COVID-19 has been addressed by the creation of this network. So central to the mandate of this network, so it's a prioritization of equitable distribution based on a public health risk and need, of course, uh, giving a particular attention for the developing countries and a population in a vulnerable situation. So the network will carry out several functions to achieve these objectives. Identify pandemic related health products, of course, identify barrier and remove such barrier to the access to the pandemic related health product, whether it's vaccine, therapeutic, or diagnostic, estimate their supply and demand, facilitate procurement of pandemic related health product, coordinate relevant procurement agencies within the global supply chain and logistic network, promote transparency, and of course collaborate on stockpiling during pandemic emergencies and also during the pandemic period. Next, please. So the World Health Organization will take the lead in developing, coordinating, and convening the network, the global supply chain and logistic network. This process will be conducted in a full consultation with the three main categories: the parties to the agreement who adopted and ratified the agreement, WHO member states who are not parties to the agreement, and as well as the other relevant stakeholders. So this global network will operate under the direct guidance and oversight of the Conference of Party, ensuring that its accountability and its inclusive approach, especially the governance of the network. To this end, the Conference of Party will play a central role in monitoring and guiding the network. So it will the Conference of Party will periodically review the network performance both during and between pandemics, assessing, of course, its effectiveness and responsiveness. Addition to that, the Conference of Party will provide and further guidance on the network operations and responsibility as needed, ensuring that the network remain adaptive, remain transparent, and aligned with the priority of all parties. There are several challenges which has been identified during the COVID pandemic and is aimed to be addressed by the creation and development of this network. Aiming to address the fragmented supply chain and inequitable access during the emergencies, also to remove barriers to procurement and delivery, especially in fragile and humanitarian settings. Also, it should enhance the coordination between the procurement agencies and the stockpile management agencies. Transparency on top of that, and also to address the delays in the stockpiling to the countries in urgent need. Next, please. So Article 14, procurement and distribution. So this article promote fair, transparent, and efficient access to the pandemic-related health product. Article 14 will address inequities, the supply disruption, as well as the issues related to the waste management to the pandemic-related health product. So this article is spanned over 7 paragraphs with a focus on the transparency and disclosure of the purchase agreement. So all parties are expected to publish the terms of their pandemic-related health product purchase agreement as early as possible, promoting a similar transparency in regional and global mechanism. Then equitable access for publicly funded agreement. Again, parties to the agreement should include provisions in a publicly funding purchase agreement that support timely and equitable access, especially for developing countries. For example, like donation, delivery adjustments, licensing, and global access plan, for example. Allocating procurement for global solidarity during pandemics and public health emergencies. Parties should reserve or arrange part of their procurement of diagnostics, therapeutic, and vaccines to assist other countries facing an unmet health needs. For the fourth paragraph, the proportionate and transparent pandemic trade measure. Parties also should ensure that emergency trade measures are targeted, proportionate, transparent, should be temporal, and avoid creating unnecessary barriers or supply chain disruption. Promoting rational use of and reducing the waste of pandemic product. Advocate for an excessive national stockpiling. So parties should refrain from maintaining an pandemic product stockpile that exceed the reasonable domestic preparedness and response need. And finally, the standards for sharing pandemic health-related product internationally. So when sharing the product through the network or other mechanism that is adopted by the conference of party, so party should provide um, an earmarked supplies with sufficient shelf life. So additionally, also they should share an essential product information, coordinate also with other member states or entities, and deliver the supplies in predictable large volume. Next, please. So Article 15, the whole of government and whole of society approach. The state parties are encouraged to adopt a whole of government and whole of society approach that are tailored to their national context, of course, ensuring that all sectors and agencies and national agencies are engaged in the pandemic prevention, preparedness, and response. So, and a central emphasis is placed also on empowering communities to actively contribute to readiness and resilience efforts. Recognizing, of course, their critical role in shaping an effective outcome. So to this end, and each state party is urged to establish or strengthen a national multi-sectoral coordination mechanism that bring together health, social, economic, or any other relevant sector. So furthermore, state parties are expected to promote an inclusive engagement of indigenous people, local communities, and other relevant stakeholders throughout the process. Article 15 highlights the need for an inclusive, multi-sectoral approach to pandemic prevention, preparedness, and response. So aiming to address gaps that has been observed during COVID-19 in coordination, community participation, social protection, and mitigating the socio-economical impact of the pandemic. So by promoting an stronger coordination, effective community engagement, and equitable participation, this article overall is aiming to strengthen the national capacities and support social solidarity, ensuring sustainable and effective pandemic response by involving everybody. Next, please. Article 16, communication and public awareness. So each state party has the obligation, as appropriate, of course, to strengthen the public understanding of science, public health principles, and pandemic-related health issues, including their causes, drivers, and impacts. So efforts by parties to the agreement should be also focused on raising the awareness of the efficacy and safety of the pandemic-related health product, such as vaccine, diagnostic, and therapeutic, with a proper management of its related liabilities. So to support this effort, the World Health Organization will provide a technical assistance upon request and extend also a particular support to developing countries. This include helping the parties to the agreement to develop and implement effective communication strategies, as well as enhancing public health awareness and understanding of the pandemic related health measures and guidance. Next, please. So Article 17, the international cooperation and support for the implementations. All parties are committed to cooperate in strengthening pandemic prevention, preparedness, and response capacities at global level, with a particular emphasis in supporting the developing countries. So this collaboration may take on multiple forms, guided by solidarity and mutual assistance. The World Health Organization is tasked uh, with facilitating such collaboration and providing support upon request, of course, of any party. So in doing so, WHO is expected to work closely with relevant international organizations to ensure that assistance reach those most in need. So furthermore to this, the parties are required to coordinate and enhance, of course, collaboration between WHO pandemic agreement, the international health regulation, and other relevant instrument and framework, and or just to create a coherence and complementarity of the global health architecture. Next, please. Article 18, the sustainable financing. So state parties are required to strengthen, sustained, a predictable, inclusive, and a transparent financing for effective implementation of the WHO pandemic agreement, with particular focus on the developing countries. So each state party within its legal capacities is expected to maintain or increase domestic funding for pandemic prevention, preparedness, and response. In addition to that, parties shall work to mobilize further financial resources, especially in form of grant, to assist developing countries. So an additional effort should also include promotion of an innovative financing mechanism that should be flexible, reprogramming of existing funds to maximize its impact. Moreover, the state party are encouraged to advance better governance and efficacy with existing financing bodies, ensuring that resources are allocated effectively and tailored to the need of the developing countries. Next, please. So continuing with Article 18, the sustainable financing, that the coordinated financial mechanisms that we discussed during the last session of the IHR amendment is established to ensure sustainable funding for pandemic prevention, preparedness, and response. This mechanism is designed to provide a surge financing from day zero of the pandemic, with a particular priority given to the need of the developing countries. It will also play a key role in strengthening the implementation of the post-international health regulation and the WHO pandemic agreement. So the CFM, the coordinating financial mechanism, will be the same entity as that established under the international health regulation, but adapted to serve both instrument under the authority and guidance of the Conference of Party. So the Conference of Party will oversee the mechanism by approving its term of reference and governance rule, selecting one or more international entities to operationalize it and finalize its operational modalities within 12 1 year month of pandemic agreement entry into force. Next, please. So again, continuing with the same the same article, sustainable financing. Again, the CFM will serve, as we said, as a central a platform for aligning and strengthening pandemic financing. Its function include encouraging needs and gaps and gap analysis and developing a 5-year financial and implementation strategy to guide investment. So it will promote and harmonize and a coordination and across financial mechanisms, including those linked to the international health regulation. So to enhance transparency, the CFM will maintain a dashboard of available funding sources and country allocations. It will also provide technical advice for the state party, supporting them in identifying and applying for an appropriate funding opportunities. In addition to that, the mechanism will mobilize voluntary and conflict-free contributions, drawing support from a wide range of sectors that benefit from global pandemic prevention, preparedness, and response efforts. So, on other hand, the Conference of Party, as we said, will play a central role in guiding and strengthening the financial foundation of the pandemic agreement. Its functions include exploring both new and existing funding sources with a particular attention to innovation, to innovative approach that go beyond traditional donor assistance. So the Conference of Party will also review and align its work with a 5-year financial strategy developed by the coordinated financial mechanism, ensuring coherence and sustainability in a global financing efforts. In addition to that, it will encourage external financial contributors to align their support with this 5-year strategy, promoting greater coordination and maximizing the impact of resources dedicated for the pandemic prevention, preparedness, and response. So it's very important to note that Article 18 of the WHO Pandemic Agreement that we just discussed and Article 44 of the IHR of the amended IHR, Article 44 bis, are designed to work in a full complementarity with both establishing a coordinated financial mechanism to support a sustainable, equitable financing for pandemic prevention. So by creating a single mechanism that serves both instrument, the agreement and the regulation, so the provisions will avoid duplication, strengthens coherent and aligning financing strategy across the pandemic agreement and the international health regulation. So having this dual mandate will ensure that resource mobilization through the CFM is not only sustain the long-term implementation of the pandemic agreement, but also reinforce the IHR core capacity, bridging the two framework into an unified financial architecture for pandemic preparedness. Next, please. So chapter 3, this is the end of chapter 2 that has been already started by Dr. Mary. So chapter 3 is the institutional arrangement, starting with Article 19, the Conference of Party. So the Conference of Party is established as a governing body for the WHO Pandemic Agreement, and it will monitor and promote its implementation by conducting a 5-year review and take also a necessary decision for an effective implementation, including coordination with the IHR Implementation Committee. So within a year of the agreement enter into force, WHO will convene it is a first conference of party session to set a future schedule, adopt rule of procedures, and observer criteria, as well as establishing a financial role and budget. And next, please. So the conference of party may establish an subsidiary body with a defined term and conditions. So delegate task to existing WHO or delegating a task for a WHO already existing WHO bodies where appropriate, and approve an a compliance mechanism by its second session. So the conference of party may establish also an implementation mechanism that is facilitative, transparent, cooperative, and non-punitive, taking a national circumstances into account. Of course, this would be guided by consensus-based role of procedures. It will review national reports and issue non-binding recommendations. For example, the recommendation under Article 4 that has been just discussed by Dr. Mary, and suggest support measures. So some extraordinary sessions may be convened either by the conference of party itself or at request of a 1/3 parties within a 6 months. Next, please. So the right to vote, who should vote? So each and how it's organized. Each party to the agreement hold one vote, while the regional economic and integration organization, such as the European Union or African Union, for example, may vote within their area of competence with a number of votes equal to their member state that also parties. So, however, to avoid duplication, these groups and their member state cannot vote simultaneously on the same issue. So, if member state vote, then the group, the regional economic and integration organization, will abstain, and vice versa. Of course, if the member state voted, so if the group voted, then the member state will abstain. Next, please. So the report to the conference of party, Article 21 require that parties to periodically report to the conference of party via its secretariat, WHO, on their implementation of the pandemic agreement, while the secretariat report on its own activity. So the conference of party decides the content, later I mean, in its very session, the frequency and the format of the report, and may assist parties, particularly developing countries, in meeting their obligations. So report must respect national confidentiality and privacy law, but subject to this will be published online for transparency as well. Next, please. So WHO, as I just mentioned, will serve as a secretariat for implementing the pandemic agreement under the guidance of the conference of party. So its role includes coordinating within international and regional organizations. The secretariat authority is limited. It cannot override the national law or mandate and mandate measures such as, for example, the lockdown, the vaccine mandate, diagnostics, or travel and border control, which remain under full national uh, sovereignty. Next, please. And yes, so settlement of dispute. Article 23 establish that dispute between parties on interpretation or application of the agreement must first be resolved peacefully through negotiation, mediation, or similar mean with the support of the secretariat. It If unsolved, so party may mutually upon agreement agree in writing to arbitration following the permanent court of arbitration, the BCA rules, or other agreed procedures that parties may agree to refer to. So these provisions also apply for the future protocol under the agreement unless otherwise specified here. For example, the instrument the PAB annex. So the mechanism also apply to the PAB annex or any other protocol proposed by any parties in the future. Next, please. So Article 24 of the relationship with other international agreement affirms that the agreement is guided by the UN Charter and WHO Constitution and must be interpreted in harmony with the international health regulation and other relevant international agreements such as the TRIP agreements, Nagoya Protocol, or pandemic influenza preparedness framework. On other hand, Article 25, the reservation, provide that parties may enter reservation to the WHO pandemic agreement, provide such reservation are not incompatible with the object and purpose of the agreement. However, a reservation, for example, or a rejection of Article 12 is expressed as an incompatible, as it would undermine the foundation of the agreement. So in this effect, for example, just giving an example, if an state party seeking to reserve or reject Article 12 would be viewed as rejecting the entire agreement itself. This is very important from the member state point of view, because it safeguard ensures the integrity and the coherence of the agreement while allowing an unlimited flexibility in other area than Article 12. Next, please. So declaration and statement. So upon signing, whether signing, ratifying, approving, accepting, or acceding the WHO pandemic agreement, so state or any other regional economic and integration organization may make a declaration or a statement, but this cannot alter or limit the agreement legal effect. Next, please. Article 27, the amendment, established the process of amending WHO pandemic agreement. It's just like the IHR. So any party may propose an amendment which the conference of party reviews and seeks to adopt by consensus. So if consensus is not possible, adoption may occur by a three-quarter majority of parties present and voting, excluding, of course, absent parties. So proposed text must be circulated by the WHO Secretariat through the function of the DG at least 6 months in advance and shared with all parties. So signatories and depositories, of course. So amendments enter into force once 2/3 of parties formally adopted them, taking an effect of 90 days after the threshold is met, with the depository, the WHO notifying all state parties. And next, please. So just continuing that with Article 27, it established a formal amendment process where proposals are circulated 6 months in advance, adopted by consensus, or if failed to reach consensus, a three-quarter majority of conference of party, and they require an individual ratification to take effect. So once adopted, WHO informs all parties who have 6 months to object in writing. So if no objection is submitted, the amendment is automatically accepted. Parties that initially object may later withdraw their objection and opt in. Next, please. So Article 29, the annexes form, it's very important to note that annexes form an integral part of the WHO pandemic agreement. So any reference to WHO pandemic agreement also include it is annexes. For example, PAB, the annex of the PAB under negotiation is an integral part. Rejecting it, it means it is a rejection for the entire agreement. Annex Article 29, the protocols. So any parties may propose protocol circulated 6 months before WHO conference of party consideration, adopted again by consensus, the same procedure, and if consensus didn't met, then voting is applicable. So only agreement parties can join protocols, and only protocol parties are bound and can vote. So protocol align with the agreement, but the protocol, it set their own entry into force and amendment rules. Next, please. So Article 30 withdrawal. So any party to the agreement may withdraw only after 2 years, with an withdrawal effective 1 year after notice. Withdrawal also applies to its protocol unless otherwise specified, but the party remain bound by the international legal by other international legal obligations. Article 31, the signature, which is open to the states and regional economical groups. So signing will begin, of course, after the Health Assembly adopts the annex described in Article 12, paragraph 2, and it will take place first at headquarters in Geneva and later at UN HQ in New York on date to be announced later after adoption of the annex by the World Health Assembly. Next, please. So Article 32, ratification, acceptance, approval, formal confirmation or accession. So according to Vienna Convention on the law of treaties, and as well as the United Nations Treaty Handbook, ratification, acceptance, and approval, the first three terms, are ways for a signatory state to confirm consent, while accession is for non-signatory state joining later after endorsement of the after the agreement enter into force. So while formal confirmation is applied mainly for the regional organizations. So in summary, so ratification, acceptance, and approval are a different way of signing the agreement after its adoption, depending on the legal formalities and domestication of the national domestication process of the agreement. The accession is for the state party that is signing after the agreement enter into force, while the formal confirmation is for the signature and adoption of the regional economical group. So the agreement may be these are very quick just clarification on these different terms. So the agreement may be ratified, accepted, approved, or acceded by the states, and formally confirmed or acceded by the regional economic integration organization. So when the organizations join without its member state, it assumes that all obligations alone, if both the organization and the state party join, so they must clarify responsibility and cannot exercise rights simultaneously, as we mentioned in the voting mechanism. So the organization must also declare their legal competencies upon joining and notifying the depository of any changes. Article 33, entry into force, sets out that agreement enter into force 30 days after 60 states have deposited their instrument of ratification, acceptance, approval, or formal confirmation or accession. For states or organization joining later, it takes an effect of 30 days after their own instrument is deposited. Organizations, the regional economical organizations, are not counted in addition to their member state. Next, please. So Article 34 designates the UN Secretary General as the depository of the WHO Pandemic Agreement, its amendment, and any protocol or annexes adopted under it. Article 33, the authentic text, of course, as usual, establishes that the WHO Pandemic Agreement is equally authentic in the 6th language of the United Nations. So the WHO, as just finally, we should, understands that the WHO pandemic agreement will strengthen the whole African health security by improving preparedness, response, and resilience. So, as usual practice of the African countries and their active participation, which has been instrumental and crucial in shaping the agreement, it's also remain vital, particularly in the upcoming PAB annex negotiation. So, unified participation will help and secure a tangible benefits and strengthening health system across our continent. Thank you so much for active listening, and I would like to welcome your questions and interventions. And sorry for exceeding the time with 6 minutes. Over to you.
Thank you so much, Mahmoud. I think we're going to have the slide quickly. And while we are having the slide, in the interest of time, those who have questions can raise their hands and ask the questions. Thank you to participants who asked questions through the Q&A, and most of them have been answered too so far. So let's take a couple of minutes just for this Slido, colleagues. The same process. What are the key principles of the pandemic agreement? Ou quels sont les principes clés de l'accord sur les pandémies? Any question in the meantime? So apologies once again because we have eaten the time by eight minutes. I think we're going to close very soon. There are no more questions in the Q&A. I do not see any hands raised. So we are happy that our participants have captured very well what has been said in regard to the key principles. You can see equity, solidarity, sovereignty, transparency, human rights, and dignity. Well done. Okay, so in the absence of question, maybe we're going to move to the next agenda item, which is the final one, on the next steps and closing. So let me give the floor to Dr. Miriam.
Yeah, thank you. Yeah, sorry. Thank you so much, colleagues, for your participation in the webinar. There was a lot to share. I think that while we may not have got everything 100%, but at least we have now a basic understanding of what is in the pandemic agreement, what are the major principles of pandemic agreement. I see that the last question was very well answered. And what are the major issues in the amended IHR? So we have also provided a list of references on the screen there. The links you can use to get to the pandemic agreement document, the amended IHR document, several Q&A documents, but also if you want to really get the basics of IHR, you want to have to go through the basics of IHR monitoring and evaluation framework, you can make reference to these links. Following this last session related to IHR and pandemic treaty, we will share the link, or we'll share an email with all the 5 recordings and the presentations. So colleagues who have not been able to follow through the different sessions can go through these sessions at their own timing to make sure that you learn more and you become almost an expert on these areas. At least you will be knowledgeable about this. And then now the next step will involve the domestication of the IHR amendments as guided in the session that we had we had last week on the domestication. There are a few activities that we need to do at the country level in order to move the implementation of the amended IHR forward. And the pandemic agreement, there's still more to be done, and you'll keep updated on when it is ready for ratification and when it is ready for domestication. For now, we have shared the key information and it is already applicable. We can already start working on those issues of technology transfer, the issues of equity and solidarity, etc. But the formal ratification process, or it will be when it is almost coming into force or after it has come into force. Now we'll have a post-session survey. The post-session survey is already in the chat. It will also be emailed to each one of you. You can copy the link from the chat. And in that post-session survey, we want you to tell us how these have been useful to you, the sessions, and also if there's anything more you feel that you would like to learn from us in the future, so that if we plan to do anything more on IHR in terms of webinars or other trainings, we can plan to address that. We look forward to hearing from you and your feedback about our sessions. Now, this will bring us to the end of the series of webinars on IHR amendment and pandemic treaty, but not to the end of webinars for capacity building in the region. So we will be alerting you on a new series of webinars in the coming weeks. For now, we'll take a short break and then we'll come back to you with the new series. We'll address topics such as One Health, topics such as ship sanitation, and all that detailed information for points of entry, for competent authorities at points of entry, so that we can work on improvements at the points of entry, but also issues related to infection prevention and control, which we realize is a big challenge within the region. Cholera control, etc. But we'll be letting you know in the coming weeks. With that, I would like to thank you all for your... I see a question. Do we still have a room for a question, Dr. Lat? I see a hand up.
Okay, so we can take maybe a couple of questions before we close.
Otherwise, what is remaining is for me to close. I see Nagwa. Nagwa, are you still on? You open. Okay.
Apologies, I raised my hand by mistake. I apologize. I was reading the answer to the question. Thank you, Miriam.
Okay, thank you. And so we have tried to answer as many questions as we can. And with that, we come to the end of our session. I would like to thank the different facilitators that have contributed to this series, both in AMRO and in AFRO. Would not maybe want to list all of them now, but it has been a joint organization between the AMRO region and the AFRO regions of WHO. And we have had the teams working together to bring all this information to you. So I'd like to extend our sincere thanks to both teams for this, and for you, our participants, for having been attentive and listened in to this information. We sincerely hope that we have shared information to you that is useful, and you have moved away with some improved knowledge about these materials. Thank you very much, and wish you the best in your endeavors. Over from me.
Okay, thank you.
I don't know if you
Yeah.
want to close off or it's over.
Yeah, it's over. Thank you.
Okay. Bye.
Bye-bye.